Moving forward, let's evaluate how we can screen and diagnose substance use disorders. Starting with alcohol, it's important to remember that there exists a spectrum of alcohol use. For example, in the United States, about 30 to 40% of individuals are abstainers. About 1/3 of the population exhibits at-risk use. This is where we would want to implement a brief intervention. And then about 10% of the population actually meets the criteria for an alcohol use disorder, which is on the severest end of the spectrum. What is at-risk alcohol use? According to the National Institute on Alcohol Abuse and Alcoholism, which is based on research in the United States, for men, more than 4 drinks per day or more than 14 drinks per week. For women and all who are aged greater than 65 years, more than 3 drinks per day or more than 7 drinks per week is considered at-risk use. It's important to remember that this does not diagnose an alcohol use disorder. However, it may alert us to an individual who may be beginning to develop unhealthy use. It's also important to remember the equivalency of 1 drink, which is equal to 1.5 ounces of liquor, 5 ounces of wine, and 12 ounces of beer. Another screener we have is the National Institute on Alcohol Abuse and Alcoholism Single Question Screening. This translates to how many times in the past year have you had 5 or more drinks in a day for men, or 4 or more drinks in a day for women. For an answer of 1 or greater, this may identify at-risk drinking with a sensitivity of 82% and specificity of 79%. Assessing the quantity and frequency. If the screen is positive, you could ask on average how many days per week do you drink alcohol? Or on a typical drinking day, how many drinks do you have? Another important tool for screening alcohol use is the Audit C. It is the most widely validated instrument, often used in primary care, and consists of a 10-item questionnaire. It can detect unhealthy alcohol use with a 90% sensitivity and 80% specificity. A score of greater than 20 suggests an alcohol use disorder. If the quantity and frequency of alcohol use meet the definition of at-risk drinking, we can ask questions related to what we'll call the 3 C's. This refers to craving, control, and consequences. Utilizing the DSM-5, which is a diagnostic tool utilized in psychiatry published in 2013 to diagnose a substance use disorder. 2 or more of the criteria in the graph need to have been met in the prior 12 months, and this is further characterized by severity. 2 to 3 criteria as mild, 4 to 5 as moderate, and 6 or more as severe. Under the first C, craving is the desire for a substance that may consume one's thoughts. Tolerance is the need for higher amounts of a substance to achieve the desired effect, and withdrawal is the removal of the substance causing severe symptoms. In the control category, criteria such as the use of larger quantities of the substance over a longer period, unsuccessful attempts to cut back or control on one's own, and increased time spent either searching for the substance or recovering from it. Lastly, in the consequences piece of the pie, the criteria include failure to fulfill major obligations, social or interpersonal problems that have resulted due to substance use, activities given up, use in hazardous situations such as driving, and use despite physical and psychological consequences in those with pre-existing medical or psychiatric conditions. Keep in mind that for substances or medications that may be prescribed such as opioids, more than 2 criteria must be met, as both tolerance and withdrawal are inherent with a medication such as this, due to physiologic dependence, which may develop with prolonged use. Tools are limited in screening for unregulated substance use. However, here are examples of a few. The Screen for Drug Use with Single-Item Screening Question, or SISQ, consists of the question, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? A screen is positive for a substance use disorder if 1 or more is answered with a sensitivity of 100% and specificity of 74%. We can also use the DAST-10, which is often used in addiction treatment settings. It is a questionnaire composed of 10 yes or no questions. A score greater than 3 is significant for substance use with adverse consequences. This screener may be useful in assessing severity. Here's a refresher on our 3 C's, which is an easy way to remember the 3 main categories from the DSM-5: craving, control, and consequences. Taking a substance use history can become quite nuanced. However, there are various frameworks that can be utilized to parse it down to something more realistic. We have reviewed screening and diagnosis already. Now let's take a look at the RIP-TEAR framework for taking a substance use history. Firstly, we have to address risks. Are there any immediate dangers to the patient? Is there a history of overdose, intravenous use, or use of multiple substances? Initiation. When did the substance use start? Pattern. What is the quantity and frequency of substance use? Treatment. Have there been prior treatment episodes? With what and what has worked or not? Effects. What are the positive and negative effects of substance use? Abstinence. Have there been prior periods of not using substances? If so, how long did they last? Lastly, a return to use. What factors can help prevent a return to substance use? Or, in other words, helping the individual identify positive coping mechanisms. A brief intervention can be utilized. It is a very adaptable and realistic tool to use when identifying one with at-risk substance use. It is an evidence-based practice designed to motivate individuals with at-risk substance use to change their practices by helping them understand how their substance use affects their health. The goal may be to reduce or abstain from the substance depending on the individual's goals. The former, with reduction, is an important concept to remember and follows the principles of harm reduction. In other words, meeting the patient where they are with minimization of harms associated with their use. The brief negotiated interview consists of 5 minutes of brief advice and counseling. It is associated with reduced healthcare costs and decreased alcohol consumption by 3.6 drinks per week at 12 months, based on a 2012 SAMHSA study. On this slide, we see an example of a brief negotiated interview. Here's a script that you could utilize when asking the questions in screeners. To break it down, we want to raise the subject and provide feedback. In other words, have the individual make the connection between their substance use and symptoms or concerns. Enhance intrinsic motivation, which consists of assessing readiness to change. Develop a discrepancy so the individual provides their reasons for motivation to change, and utilize reflective listening. Lastly, negotiate and advise. Negotiate a goal, offer practical advice, summarize, and suggest a follow-up plan with a concrete timeline. Motivational interviewing is a very useful tool to use, and we encourage you to utilize it. An acronym that we use to remember the 4 principles of motivational interviewing is OARS. Open-ended questions should be utilized early on in the interview, allowing for description to avoid a yes or no answer. This helps build rapport and trust with the patient. Affirmation of the patient's feelings can create a sense of validation, praise, and a safe space. Providing reflective listening, which consists of echoing the patient's thoughts and feelings, is invaluable. Summarize with purpose. Create transitions and goal setting that is practical and feasible within the environment in which you are.